So I'm going to talk on corneal involvement in atopic and vernal keratoconjunctivitis. But before I do that, I'd just like to give a recap back to your medical school days where you can remember the different types of hypersensitivity disorders that we were taught. And this is important when it comes to how we treat these conditions. So seasonal and perennial allergic conjunctivitis are type 1 or immediate forms of hypersensitivity, which means they're mainly immunoglobulin mediated, whereas vernal and atopic, along with contact dermatitis, are type 4, and so they're cell mediated. So type 1, you have high locally produced levels of IgE, and you can find to the specific allergens that are found in tears. And you can reproduce these with things like the skin prick test. And when you look at the tissues, there's lots of mast cells and eosinophils in the mucosa and submucosa. The difference between the seasonal and perennial is just whether the seasonal is intermittent, as suggests with the seasons, and the perennial is year-round, with seasonal affecting more children and young adults and perennial more common in adults. Seasonal is very common, perennial also common, but both are pretty well mild and non-progressive. Management of these conditions is often fairly simple by identifying the triggers and having the patients avoid them. And one of the common triggers we see at home is house dust mite, and people that haven't have carpeting in the bedroom, don't wash their pillowcases, change their pillows regularly, can be more susceptible. Cold compresses and lubricants can help. Then there's a range of topical antihistamines and mast cell stabilizers, but we really don't know about their long-term use because data is missing. Topical non-steroidal anti-inflammatories can be used, but they often sting and burn, and there's a risk of corneal melt. There is a role for systemic antihistamines and mast cell stabilizers, particularly when people have things like hay fever or allergic rhinitis. But it's these type 4 hypersensitivity disorders where we become concerned about the cornea. These are delayed and they involve the T cells, so there's a cellular response. Vernal is seasonal but can become perennial if severe and occurs in children, as opposed to atopic, which is generally perennial and occurs in adults. Both are not that common, but both can have corneal signs which threaten vision. And with the vernal, it usually resolves in 2 to 10 years with good outcomes, but occasionally can become atopic, whereas atopic disease is often severe and progressive. This tells you everything you need to know about vernal keratoconjunctivitis and who gets it. It's typically young boys in hot climates. But how does the cornea become involved and why is sight threatened? Well, it can be threatened through the direct effects of the keratoconjunctivitis, through secondary ocular surface disease, associated diseases, and the effects of treatment. So for the direct effects of the diseases, AKC and VKC, is that you end up with punctate epithelial erosions, and these are on the superior cornea and can progress to ulceration, as opposed to dry eye where the changes are mainly inferior. Over time, if it's persistent, there can be corneal scarring and neovascularization, and up to 1 in 10 with VKC can get a shield ulcer, and a small percentage can actually end up with limbal stem cell deficiency. So this is the typical course of events. When you get this punctate keratopathy, you then get a macroerosion, and into this you get deposition, which causes a plaque, and this is a shield ulcer. If you remove the plaque, you can get scarring, a ring-like scar. So that the trick in managing a shield ulcer is to control the inflammation, control the allergy. And you do this with topical steroids, and then prevent any mechanical trauma with the lubricants, and you may need a bandage contact lens. If you end up with the plaque, you usually have to debride it. You can consider amniotic membrane transplant if you need, and PTK if the centre of the cornea is involved, to help reduce the scarring. But this is not the only way the cornea becomes involved. Patients with AKC and VKC often end up with dry eye, and this is due to the chronic inflammation. It alters the mucin layer, you get drop out of your meibomian glands, nerve sensitivity decreases, and then the lids get thickened, which reduces their blink rates, and at night typically they'll have lag ophthalmos. Associated diseases occur with AKC and VKC, and the main one, as you all know, is keratoconus, and we think this is exacerbated by chronic eye rubbing. And keratoconus tends to develop at a younger age in the presence of atopy. So all of your young patients with VKC, please use tomography or topography to screen them for keratoconus. If these patients do come to grafting, if they have these conditions, there's an increased risk of sclerokeratitis. So post-operatively after a graft, the patients can get a severe immune reaction. And this is a patient that we were treating who ended up needing systemic immunosuppression to actually deal with this severe sclerokeratitis. We initially started steroids orally, then intravenous, but it still wasn't enough to control the inflammation. And there's a risk of melting if these patients get intrastromal rings for their keratoconus. Keratitis is also more common, and in these cases, Staph aureus is the prevalent microorganism because you get colonization of the skin at increased rates in atopes. Herpes simplex, which is typical unilateral disease in patients with AKC and VKC, can be bilateral and recurrent. So it can be a bit of a diagnostic dilemma because you don't expect to see it in both eyes, but remember it in this patient group. What about the effects of treatment? Well, up to 25% of young patients being treated with steroids with VKC can end up with a pressure response, particularly if the stronger steroids such as Maxidex is used. And so they can end up with glaucoma. And then with all the treatments, particularly when they're preserved, they can get toxicity. And then if they happen to get a keratitis and treated particularly with fortified antibiotics, there's more toxicity. And this slide here shows inferior conjunctival ulceration, which is typical of this toxicity. So how do we manage these severe conditions? Well, this is where it comes back to understanding that it is a hypersensitive disorder where the T cells are involved. So we need to suppress T cell activation. And this can be done with topical cyclosporin. And so for severe cases, we get this made up to 1%. It does sting, so you have to warn the patients. Tacrolimus can also be used. These slides here are from a publication looking at the use of tacrolimus and also with steroids over a year to quieten the eye down. But even with tacrolimus as well as steroids, there's an increased risk of herpes simplex, and raised intraocular pressure has been reported. So please follow the patients up and check their IOP. This is just a recap on the different types of steroids that you might use. And the best ones in these chronic cases, if it's sufficient, are these low-potency steroids such as fluorometholone and loteprednol. Because when you have your high-potency steroids, there's an increased risk of glaucoma, particularly for dexamethasone. When the disease becomes severe or is very recurrent and has not responded to topical therapy, then systemic immunosuppression might be needed. And the choice of agent here really depends on the patient's age, but also on any other comorbidities they might have. So generally cyclosporin systemically is reserved for people with good kidney function who are young. But now we have a range of biologics which are proving to be very useful. And in some cases, immunotherapy is required. So there is dupilumab, which is very effective for atopic dermatitis. And so a lot of patients with AKC may now be on this medication. And it suppresses signaling and therefore modulates the cell responses. Now, there have been reports of increased ocular symptoms with dupilumab, and the incidence of conjunctivitis has been put between 10 to 70%. It's more likely if there's severe dermatitis, and most can be treatable with topical therapies whilst the patient maintains their treatment. The studies that reported this initially didn't really check their eyes beforehand, so we don't know how much of a problem this is. This is a range of other biologics that are emerging to potentially treat this disease, and I won't attempt to pronounce any of these names. Surgery is possible, and subtarsal steroids can be considered in the young, but once you've done this, you can't reverse increases in IOP. and giant papillae have been excised, and corneal scarring can be treated with talc. Superficial keratectomy is a surgery for shield ulcer, AMT if you've got a persistent defect in the setting of a shield ulcer. Transplantation can also be considered for the limbus, and in some severe patients they may end up with a Boston Cape Pro. So managing ocular allergy, this is my last slide, avoid the allergen and try simple measures, but this is mainly for the type 1. First-line topical therapy can be used in type 1 and type 4, but second-line therapy really for persistent cases. Surgery is generally only needed for non-healing shield ulcers.
In this part of the world, shield ulcers.
Yes.
So maybe, do you want to highlight that for steroids, do you want to give a supratarsal steroids or role of systemic steroids in these shield ulcers? I'm asking this question because we do see here much more than I think.
Look, generally we treat, I work at the Sydney Children's Hospital, and so we see a fair range of these children. And so usually, you would try with topical steroids first. If that's not working, then we would move on to oral steroids. Generally, the subtarsal steroids, if they're young, requires some form of sedation or anesthetic, and you can get permanent eyelid scarring and depigmentation, and you can't sort of alter the dose, whereas oral steroids, you can quite nicely alter the dose.
We have been using this supratarsal steroid injections for shield ulcers. Of course, you need to rule out the patient is not a steroid responder. Of late, last 2 years or so, we have shifted to systemic steroids, and what we found that it's almost the same rather than giving those injections, and that works decently well because overall it's a systemic issue, although it's exhibiting there locally, so that also works decently well.
Yeah, and the systemic steroids also helps the other eye, because generally both eyes are not doing well.
Thank you so much.
I also want to ask, like when these cases of steroid responders are there, many times we have also used aspirin because it's a prostaglandin inhibitor. So like we've been using that also for the steroid responder. What is your thought? Aspirin.
Aspirin, no, we have not used aspirin so far, and personally I don't have any experience with aspirin.
Yeah, no, but that sounds like a good idea, but
so
yes.
We give it in low dose, so we get very good results, because many of the time cyclosporine is not available in this part in topical form. So when the steroids, if you don't have an option, we give that.
So in our practice, cyclosporine we use when we want to use steroid sparing agent. As Dr. Watson said, that sometimes these patients, they need a lot of steroids and you can't give it for so long. So there only we give them, and in kids also, because many times we see it's perennial. It's not just that particular area. So there sometimes you need a systemic cyclosporine.
Yeah, we often start with the steroids to calm everything down, because generally the things like cyclosporins don't work initially. They can take time, and they struggle to work if you've got severe inflammation. So the trick is to get that balance, but we always aim to reduce the steroids as much as possible. Question about the use of systemic anti-inflammatories. Look, they do have a role. I had a child recently, and he just wouldn't open his eyes. His vernal was so bad, and so parents couldn't get near him to put any drops in. But with a short course of oral prednisone, it really improved his condition. So it is a tool in the box that we need for these, for VKC. In terms of the anti-VEGFs, the issue is that once the vessels are there, so the anti-VEGFs act against neovascularization, new vessels. So if you have established vessels, then they don't really work so much, and you need to treat the underlying cause of what's causing the vessels. People are now reporting the use of things like mice injecting mitomycin C into the vessels, and it really depends how extensive the vascularization is. Because if it's 360 degrees, then that's really sort of stem cell failure. So if you do have a vessel that is leaking lipid into the towards the center of the cornea, then you can look at these measures. Another one is just diathermy of the vessel. You put a 10-0 nylon needle through and tap that needle, and that will diathermy the vessel. So that is a technique that's useful for these sort of localized vascularization, where you've managed the underlying reason why it's there.